Christopher Robinson was 18 years old when he was sent to Rikers Island. They shipped him to Rikers because while he was on probation, he worked late and missed his curfew. When he arrived at Rikers, he was met with a systematic program of extortion and beatings led by a team of correctional officers and other detained people. Unwilling or unable to follow their orders, Christopher was beaten to death one night in his cell with full participation of correctional officers. I learned about this horrible murder when I started as the deputy medical director of the New York City jail system. One of my tasks was to work with doctors, nurses, and other correctional health staff to understand this and any other deaths that occurred among our patients. As we looked into Christopher's case, it became apparent that scores of young patients in the same building had sustained hand and jaw fractures, often during interactions with correctional staff. These violent incidents were often chalked up to the aggressive nature of detained people, but to us, they were serious injuries to our patients. At the time, I also worked outside the jails in a clinic that served survivors of torture from other countries. We documented their injuries from that horrible abuse. Working with torture survivors taught me skills I needed to recognize and understand what was happening to our patients inside the New York City jails. Lacerations from handcuffs, along with fractures of the nose, eye socket, and jaw, were just some of the injuries that I treated in both places. Looking into injuries inside the jails required creating a new injury surveillance system. We connected that new surveillance system to an electronic medical record, which allowed us to analyze these health outcomes in the aggregate. This approach revealed that violent injuries were disproportionately occurring among our young patients and our patients with behavioral health problems. It also revealed that many patients reported being injured after they had been restrained by correctional staff. I started thinking about how the jail setting itself could pose health risks to our patients. Health risks like exposure to solitary confinement, being sexually abused, or being denied medical care that was clearly needed. As I took on more responsibility within the system, my team and I identified two specific and deadly health risks of jail. The first was something we call jail attributable deaths. The second was something medical ethicists refer to as dual loyalty. Jail attributable deaths are cases where a patient dies in large part because of something that happens behind bars, whether it's being beaten to death like Christopher Robinson or being denied medical care they clearly need. Sometimes a patient dies after being locked alone in a cell as a response to a mental health crisis where they commit suicide. We documented that most years between 15 and 25% of deaths were jail attributable, but some years it rose as high as 50%. This investigative approach is fairly common in hospitals and other community settings, but jails and prisons are often operated to keep the truth from prying eyes. The question of whether conditions behind bars contributed to a person's death is rarely asked. The other area we put heavy focus on was dual loyalty. This is the pressure that results when the demands of the security setting or the way it's run create a conflict with the health mission of the medical staff. For example, when a doctor ignores clear signs and symptoms of a medical problem because the patient is viewed as problematic by security staff, that's a small example of dual loyalty at work. We started to train jail and prison health staff on this concept of dual loyalty and explored how we could help them and help our patients. One dual loyalty training scenario involved a physician being pressured to document an injury resulting from a fight between detained people, even though the patient reported being hurt by correctional staff. 92% of staff we trained said they were familiar with this kind of thing happening. Another dual loyalty training scenario involved correctional officers beating patients inside clinic cubicles in full view of health staff who were told to move to the back of the clinic, out of earshot and out of line of sight. 15% of staff we trained said they were familiar with this kind of thing happening. Imagine the long-term consequences of witnessing or experiencing this kind of physical and psychological trauma without anyone in power acknowledging the truth. As we looked into jail attributable deaths and dual loyalty, many of the structures of power in the New York City jails worked against us. In 2012 and 13, we'd identified many of the most brutal practices as occurring in solitary confinement units, places where mentally ill patients could be locked alone in a cell for days, weeks, months on end for violating jail rules. Horrible outcomes were being reported in these settings, including deaths and serious injuries in the press. Our increasingly detailed injury reports were documenting the same thing. This information and the struggle over jail conditions caught the interest of the United States Department of Justice, which is charged with investigating abuse and neglect behind bars. One data point from our records proved critical for federal investigators. We'd found that young patients who were in a violent incident were more likely to sustain a blow to the head if that incident was with a correctional officer than with another detained person. The Justice Department launched a formal investigation and found that a pattern and practice of brutality did exist. The result was a settlement with New York City that in part led to the adolescent patients being transferred off Rikers Island and ultimately out of the hands of the Department of Correction. Unfortunately, many of the abuses we documented are still going on, but the transparency around data reporting means that the problems are finally in public view, and the New York City Council has voted to close Rikers Island. What makes Rikers unique is not the brutality. And it's not the jail attributable deaths or the dual loyalty. What makes Rikers unique is being one of the few independent correctional health services in the nation. And this independence allowed us to find and report these problems. Around the country, we have 5,000 county jails, state and federal prisons, and immigration detention centers. One of the central reasons these health risks aren't known to most of us is because the health services are part of and controlled by the security service. That means the health of detained people is ultimately not managed by healthcare professionals. Time and time again, critical health decisions and policies are controlled by the security forces. The sheriffs and commissioners of correction have the authority to decide the scope, the quality, and the transparency of health services and outcomes. No Joint Commission, no CDC, no State Department of Health, no evidence-based lens or prying eyes. And conditions in these places are often as inhumane and harmful to health as at Rikers. But we simply don't know or don't hear about them. For example, the leading cause of death in US jails is suicide. This represents jail attributable death. Many people who arrive in jail need both mental health services and treatment for substance use disorders. Often, they receive neither. So they're forced into withdrawal without evidence-based treatment, and if they express suicidal thoughts, they're thrown in a solitary confinement cell, and quite a few of them commit suicide. Nothing close to a community standard of care exists for these patients, and the response to their health problems is often punitive and increases their risk of death and disability. So how did we get here? 55 years ago, Congress passed the Social Security Act of 1965. This bill included a prohibition against the use of federal funds for institutionalized people, including prisoners. 11 years later, the Supreme Court ruled in the case of Estelle v. Gamble. This landmark ruling established the right of prisoners to health care, but the Supreme Court ruling did not mandate federal spending or transparent supervision of that care. Spending and control were still left in the hands of states and localities. The significance of the 1965 law's inmate exception went far beyond funding. It meant creating a two-track system of healthcare in our nation. In the community healthcare track, we built a culture of quality improvement and transparency in our hospitals, nursing homes, and ambulatory care settings. In the correctional health track, these tasks were left to sheriffs and commissioners of correction with whatever local funds they could raise. The result has been secrecy and lack of accountability. Many of the deaths I've investigated around the nation were never reviewed to determine whether a clinical standard of care was met or whether a practice inside the jail or prison contributed to the death. To make matters worse, if the only review that happens is a coroner's report, then the determination may very well be that a person died of natural causes, such as a complication of diabetes, not that they died because they were denied their insulin. What would happen if we covered up deaths from central line infections in hospitals or falls out of bed in nursing homes in the same way? We know what would happen. We'd have many more of these kinds of deaths. The truth would rarely come out, and the problems would continue year after year. If it sounds like we have a lot of problems in correctional health, we do. But we also have plenty of potential solutions. The first step is to finally connect our evidence-based systems of care in the community to the services we provide behind bars. This will not only improve the quality of care, it will establish for the first time the true health risks that these institutions create for incarcerated people and how those health risks are mediated by race and behavioral health status. At a national level, it would make a tremendous difference if we eliminated the inmate exception in the Social Security Act. This one change would allow us to use Medicaid funds and quality metrics for the provision of care behind bars. Then we could start doing simple, basic things like measuring racial disparities in the provision of care or asking incarcerated patients how well their providers are doing. When we adopted these basic approaches in New York City, we didn't find any data to compare ourselves to. Why not? Because other correctional settings are not collecting or reporting this kind of information. Here's another change that could make a big difference. We could grant states Medicaid waivers to create local innovation using Medicaid funds for incarcerated people. There's also an important role here for the CDC and state departments of health. They already monitor health outcomes and quality in the community, and they can do the same thing in jails and prisons. And when they do, we're going to learn some alarming things. When we started investigating blows to the head in New York City, we found frightening rates of traumatic brain injury, TBI, among our patients. These rates were far in excess of anything reported in any community settings, in youth sports, even military service. Think about that. Think about the profound racial and socioeconomic implications. Today, the CDC spends millions of dollars to detect and prevent TBI in youth sports, but it has not $1 dedicated to finding or preventing the same problem behind bars. Add in the long-term impact of TBI, including dementia, and this one clinical problem lays bare the segregation built into our national model of healthcare. All of the changes I'm suggesting could be considered a good start, and in fact, I think they're crucial. But any improvements we make to correctional health services could be fleeting unless we mandate that every jail and prison report out basic quality benchmarks. This absolutely includes injuries and jail attributable deaths. This approach will allow us to finally benchmark which systems are seeing the gains of innovation and which systems are struggling. And crucially, it will help us rethink the risks and benefits of incarceration itself as compared to community-based treatment, especially for people with behavioral health problems. You might say that for the last 75 years in this country, we've been conducting a giant social experiment on health. We've been providing community health services with one set of rules and standards, and correctional health with a completely different set. You might even say we've been testing whether a policy of separate but equal could possibly be applied in the field of health. Well, the results of the experiment are in. Separate but equal works against the health of incarcerated people. And by the way, it also works against basic justice for people behind jail and prison walls too. And what's more, it works against building a just society outside those walls as well. This unconscionable divide between our two systems of health exists because we created it, because we tolerate it. We have all the skills we need to eliminate this artificial divide. And the only question that remains is, will we care enough to fix it? Each of us has our own relationship to promoting health, but a central virtue of our mission is that when we hear about patients who need our help, we act. Thank you.